Want to welcome everybody to this week's Happy Hour seminar. We're doing something a little bit different today. We're going to do a 5-case mini CPC. This was a suggestion from some of the participants. So if you have any questions, as always, you can post them to the chat. I'll stop and look from time to time. If you think of something after the fact or you aren't watching this live, you can submit them to my email, tdavis@sagisdx.com or education@sagisdx.com. And just for those of you who are listening, I wanted to let you know that this Thursday evening at 5 o'clock, we're going to be running a panel discussion for anybody who might be interested in dermatopathology fellowship training. It'll be kind of an informational seminar, and we'll have some people who just applied for fellowship and gone through the application process, some dermpath fellows, a fellowship director, and we've assembled a group of dermatopathologists who practice in a variety of different clinical settings to answer any questions you might have about careers. So hopefully you can join that if you've got an interest. If not, we'll tape it and put it on our website, on our YouTube video. And so if you know of anybody who's interested, please get the word out. So without any further hesitation, we'll go ahead and get started on our little mini CPC here. Okay, our first case. Case 1. You were given the clinical history that the patient was a 5-year-old male. What I didn't tell you was that he had a several-month history of intermittent genital swelling. And as you can see in the clinical images on your right, there is quite a bit of edema involving the penis and the scrotum, also a little bit of erythema. Of note, his mother also reported that he had some intermittent abdominal pain and a little bit of constipation, but certainly no bloody stools, no fissures, no tags in the area. There were 2 biopsies that were obtained by a pediatric dermatologist. And in the first one, and we'll take a look at 2 of them, you had 2 to review, similar findings, bisected punch. And as expected, there are ectatic vessels here. Let me tilt the slide here. In the papillary dermis, a little bit of pallor consistent with edema, a little bit of a perivascular infiltrate of lymphocytes, and then present throughout the dermis, there are a few collections of epithelioid histiocytes. Here, there's one right there. And down here, we have another collection of epithelioid histiocytes. These are surrounded by a narrow cuff of mononuclear cells, but many of these, while they're not real tight, are relatively naked, if you will. Let's look at the second biopsy, also a bisected punch biopsy. And as we move to higher power, again, there is edema present within the reticular dermis, very dilated vessels, consistent with the clinical picture of edema. And again, we've got these collections of, let me see if I can lock the slide in, collections of epithelioid histiocytes within the dermis, some adjacent to dilated vessels, and a brief, or not a brief, a very subtle cuff of mononuclear cells. Examination of these sections with routine and polarized light revealed no foreign material, and PAS, GMS, AFB, and tissue gram stains were negative for organisms. And on the basis of these changes and the clinical presentation, a diagnosis of metastatic Crohn's disease was rendered. The patient was referred to a pediatric gastroenterologist, and subsequently on examination, diagnosed and biopsy, diagnosed with Crohn's and gluten-sensitive enteropathy. He was placed on a gluten-free diet and treated with mesalamine, and over the ensuing months had complete resolutions of his symptoms and also of the edema in the genital region. So this was kind of a cool case. I haven't seen many cases of metastatic Crohn's disease. By definition, it's defined by granulomous lesions in a site discontinuous from the gastrointestinal tract. It's pretty rare. Children are more likely to present with metastatic Crohn's in the absence of any GI symptoms, or as in this case, only with mild GI symptoms. And the cutaneous involvement, this metastatic Crohn's, can actually precede the development of Crohn's disease by months to years. The most common presentation of metastatic Crohn's disease, as was manifest in this case, is genital swelling. And because a certain percentage of these patients present with this cutaneous involvement before GI involvement, it can be important to identify these and make sure that they're followed regularly by gastroenterologists for the subsequent development of Crohn's disease. The histologic differential diagnosis also includes a variety of entities which are characterized by the presence of sarcoidal granulomas, that is, collections of epithelioid histiocytes devoid of a significant cuff of mononuclear cells. Conditions that can present with this pattern, of course, are sarcoidosis and a variety of infectious conditions, including atypical mycobacteria, deep fungal organisms, et cetera. And so as a result, you kind of back into the diagnosis of Crohn's disease. You need to take a detailed clinical history. You have to rule out infectious processes with special stains and examine the sections with routine and polarized light to rule out any foreign body reaction. Okay, go ahead and moving on to case 2. Case 2, the patient was a 17-year-old male. What I didn't give you in the history was he was actually from Guatemala. Over the ensuing months prior to presentation, he had actually migrated from Guatemala to the United States, crossed the border illegally in the Rio Grande Valley, and was subsequently picked up and put in a detainment center. Now, over the months that it took him to get from Guatemala to the United States, he'd slept outdoors a lot, had a lot of mosquito bites, and he was noted in the detainment center to have this enlarging ulceration, painless, on the back of the ear. And he was referred to a pediatric dermatologist in San Antonio who did the biopsy. And the biopsy from this lesion that hopefully you had a chance to look at, quadrisected shade biopsy. And one can see quite a bit of epithelial, pseudoepitheliomatous hyperplasia, epithelial hyperplasia. I think I'm going to flip the slide and look at the top piece in the dermis. And one can see we have a nodular infiltrate in the dermis, lots and lots of clear spaces centrally, and then some darker staining cells out at the periphery. And out at the periphery, we have a lot of lymphocytes and several scattered plasma cells. And if we look at the more clear staining areas, we can see that we actually have very large histiocytes with cleared out cytoplasm. And with little effort, one could see that there were organisms present within the cytoplasm of these histiocytes, producing so-called parasitized histiocytes. And the organisms are very small, 1 to 2 microns. And we can use our erythrocyte here as kind of a ruler. Most erythrocytes and lymphocytes have nuclei that have diameters about 5 to 6 microns. And so you can see that these round organisms at the periphery of the histiocytes are about 1 to 2 microns. And really, when you, as you'll see in a subsequent slide, when you see parasitized histiocytes with organisms of this size in the cytoplasm, you're either dealing with histoplasmosis or Leishmaniasis. And of the two, Leishmaniasis has a tendency to cluster at the periphery of the cell, producing the so-called marquee sign, because the organisms resemble lights that are usually at the periphery of a theater marquee, or some have likened this to the Ferris wheel sign, with the organisms being the cars at the periphery of the Ferris wheel at amusement parks. In this particular instance, We did make the diagnosis of cutaneous leishmaniasis. And we, in conjunction with the pediatric dermatopathologist, contacted the CDC. We sent the tissue block, formalin fixed paraffin embedded tissue, to the CDC for PCR, and the patient was diagnosed with Leishmania mexicana. And it's a good idea to speciate New World Leishmaniasis organisms, because some of the organisms can cause pretty pronounced mucocutaneous disease. And if the patient is diagnosed with one of those organisms, then the treatment definitely needs to be a little bit more aggressive, and the patients need more active surveillance. You can, if you have a case of suspected leishmaniasis or diagnosed leishmaniasis, you can just go onto the cdc.gov website. They have a specimen collection guide and a specimen submission guide, and they do ask that you contact them before submitting either tissue blocks or fresh tissue for diagnosis, so that they got a heads up. And very, very helpful, and a good idea to involve them. In this last photomicrograph, I've got a case of leishmaniasis on the left and histoplasmosis on the right. And again, you've got small caliber 1 to 2 micron organisms and histiocytes in both organisms. In leishmaniasis, you get these clear spaces that kind of look like soap bubbles in the tissue because of the tendency of the organisms to locate at the periphery of the cell, whereas in histoplasmosis, there's a tendency of the organisms to locate or to cluster within the cytoplasm of the histiocyte, so you don't get those clear spaces, but the two are quite similar. There have been some case reports in the literature about using CD1A staining in cases of leishmaniasis, and I have noted in a couple of instances that CD1A immunohistochemical stain will highlight the organisms. Actually, in my hands, it's a little bit better than GIMSA, but usually you can see the organisms on H&E, and the clinical will help you as well too. And then again, you can get confirmation via PCR. Okay, let's go ahead and move on to case 3. Case 3 was a fairly straightforward case. 76-year-old female who presented with a several-year history of this slowly enlarging, painful erythematous plaque on the leg, very indurated. Looks a little yellow over at the periphery, a little red centrally, and a large punch biopsy through this lesion reveals evidence within the papillary dermis of nodular angioplasia. So we have a little bit of stasis-related vascular change, but not much inflammation. In this particular instance, we have a rip-roaring paniculitis here. And we have a lobular paniculitis. If you take a look at the fat here, there's total distortion of the architecture, and this is barely discernible as subcutaneous tissue. But there's not a lot of inflammation. There aren't many viable adipocytes left here. A lot of the adipocytes have kind of ruptured and fused. And so we've got these large fat microcysts. And if we look at the periphery of the fat microcyst, we've got this lipomembranous change, this kind of arabesque type fibrillar material out at the periphery, which basically represents coalescence of remnant cell walls of adipocytes. In addition, within the surrounding tissue, there's a little bit of fibrosis. There are a few lipophages and a very sparse infiltrative lymphocytes, and in this case, a few plasma cells. And of course, these findings are virtually pathognomonic for lipodermatosclerosis, especially in this clinical setting. Personally, in my practice, I see a lot more biopsies of lipodermatosclerosis than I do erythema nodosum. And I think I would say over the course of the last 20 to 25 years, with more recognition of this condition clinically, I'm seeing fewer and fewer biopsies, but I thought this was just a real nice example with good clinical pathologic correlation. Okay, case number 4 The patient was a 68-year-old male, and he came in with a several-year history of progressive telangiectatic mats. These actually began, and I don't have a picture of it, on his lower legs, on the thighs, with extension onto the abdomen and subsequently onto the upper extremities. These were asymptomatic, had their onset in his late 40s, were progressive. There was no family history of such. He had no involvement of mucosal surfaces, and there was no history of gastrointestinal bleeding or nosebleeds, and no history of anemia or anything. A biopsy was done from one of these patches, telangiectatic patches or macules on the arm, and biopsy showed, this bisected punch biopsy shows not much in the way of an inflammatory infiltrate. The findings are actually pretty subtle. The epidermis is of normal thickness, but if we hone in on the papillary dermis, we can see that there are several ectatic vessels present, which really is not surprising given the clinical presentation. There's not much of an inflammatory infiltrate, but if we take a look at the vessel walls, we can see that they're kind of thickened by this homogeneous kind of hyalinized pink material. And a PAS stain, which we'll look at now, kind of highlights this hyaline material around these ectatic vessels. And when coupled with the clinical presentation, these findings are diagnostic of cutaneous collagenous vasculopathy, which is an acquired condition. There was a very good review of the condition about 4 years ago in the American Journal of Dermatopathology. It was one of these reports of 2 cases with review of the literature, 36 cases discussed in total. And what the authors found was that this was a disorder that more frequently occurred in middle-aged to older women. As was the case in this patient, it was asymptomatic and slowly progressive, and his history was absolutely classic. These lesions usually first appear on the lower extremities and then progressively spread upward to the trunk and upper limbs. The mucosal surfaces, head and neck are spared, and the treatments have been largely unsuccessful. The microscopic findings are very characteristic. Usually one sees, as was demonstrated by this case, dilated capillaries in the superficial vascular plexus. They're thickened by deposition of this eosinophilic PAS positive material, which immunohistochemically is type 4 collagen. And on electron microscopy, there's duplication of the basement membrane. Other conditions to consider in anybody with generalized telangiectasias. The 2 biggies are hereditary hemorrhagic telangiectasia, of course. The other big consideration is hereditary benign telangiectasia. But both of those conditions are characterized by onset at an early age. In both instances, there's a positive family history. In the former, there is classic systemic and mucosal involvement with chronic bleeding, whereas there is no such history in the case of hereditary benign telangiectasia. And then, you could consider, you need to consider other conditions, ataxia, telangiectasia, angioma serpiginosum, TMEP, but usually the constellation of signs and symptoms, associated symptoms, make these conditions easier to diagnose. So the take-home point, really you need to add cutaneous collagenous vasculopathy to your differential of acquired generalized telangiectasias. It's rare, but I think it's probably undiagnosed. I mean, I think there are a lot of patients who probably come in with a history of progressive telangiectasia who never have biopsy done. biopsies done, especially if they don't have much in the way of symptomatology. And while the clinical picture is characteristic, really this is a condition that requires clinical pathologic correlation. So in order to make the diagnosis of certainty, with certainty, you really need histologic confirmation. Okay. And our last case, this case was kind of cool. I've never really seen this before. The patient was a 59-year-old male who presented with a several-week history of a blistering eruption. And you can see on the extremities and here on the volar surfaces, he also had involvement of the trunk, erosions and kind of tense bully. Some of them are on an erythematous base, and others are eroded and crusted. Involvement of the fingers here as well. And so a biopsy was done for both H&D and immunofluorescence. Let me flip the slide here. The staining, I'm sorry, is not so great. But one can see the presence of a subepidermal blister here. This is relatively cell-rich. There's fibrin and inflammatory cells in the papillary dermis and in the blister cavity. And if we look at the inflammatory infiltrate, there are lymphocytes and scattered eosinophils present within the dermis, some festooning or retention of the dermal papillae, and lots of eosinophils, some extravasated erythrocytes, lymphocytes, and a few neutrophils in the blister cavity. And so, I'm thinking this is pretty good for BP, especially given the clinical presentation. And sure enough, on direct immunofluorescence, there was linear IgG, and I didn't show the C3, but there was linear IgG and C3 along the basement membrane zone. And so, classic for BP. But interestingly enough, at the time of IF, the IgA showed granular staining in the dermal papillae. And so I'm thinking, what is going on? So I called the clinician, and he went back and spoke to the patient. And on further questioning, the patient admitted to a long-standing history of gluten-sensitive enteropathy. He also had a remote past history of dermatitis herpetiformis, but he had been on a gluten-free diet for years and had had no problem with either abdominal pain or the dermatitis herpetiformis. And he didn't even mention it at the time of initial presentation. And so I went backwards, sorry. So what we've got here is a case of concomitant bullous pemphigoid and dermatitis herpetiformis. And I really had not encountered this before. But when I did a literature search, I found an article published out of Finland in the Journal of Investigative Dermatology in 2019. And the authors looked at a big cohort of patients in Finland, and they found a significant association between dermatitis herpetiformis and bullous pemphigoid. As a matter of fact, they found that patients who have been diagnosed with dermatitis herpetiformis had an increased risk of bullous pemphigoid 22-fold. It led them to conclude that if the clinical picture of a patient with DH changes, or if they become unresponsive to a gluten-free diet, it's important for dermatologists to recognize this risk of DH evolving into BP. And it's believed that it may be genetic, or the scratching from DH may expose the antigen, and then the patients develop antibodies. But just kind of a cool case. I'd never seen that before. So that's all I have. If you have any questions about the cases, please feel free to email me at tdavis@sagisdx.com. And we tend to see some really good cases from time to time. And when we get good clinical pictures, I think we'll go ahead and do some CPCs from time to time. We appreciate any feedback on this. And if you guys like cases like this, please be sure to let us know. Thanks so much, and I hope you can join us on Thursday for the Dermpath Symposium if you're interested. Thanks. Have a good evening.